Lakeland Currents is sponsored by Nisswa Tax Service. Nisswa Tax Service offers tax preparation for individuals and businesses across from City Hall in Nisswa and on the web at nisswatax.com.
Hello again, everyone, and welcome to Lakeland Currents, where my guest today is Tim Rice, who is the president of Lakewood Health System. The hospital is located between Staples and Motley, and there are a number of clinics in central Minnesota and some of the smaller communities around the area. And we're going to talk today about what is probably commonly known as Obamacare. It's not the technical name for the program, but we're going to try to put some clarity to what this particular program is going to do to hospitals, and specifically what it'll do to us as patients and customers of the hospitals. But before we go into that, I'd like to say that this hospital has been one of the most awarded, I think, in the last 10 years in probably all of Minnesota. That may not be a totally accurate statement, but if I have a list here of all the awards this place has received in the last 10 years, it's unreal. Just to give you a few examples, 2013 awarded the 2013 Women's Choice Award for America's 100 Best Hospitals for Patient Care, awarded an IU Care Minnesota's Overall Performance Quality of Care. Lakewood's IT division was recognized as one of the 5 best small hospital workplaces in the United States for the second year in a row. They have the 2000 Nurse Caregiver of the Year. They have the Caregiver of the Year. Helen Kimball was a certified resident assistant. This was going back a couple years ago. Innovation of the Year, Rural Health Team Award. It just goes on and on and on. And that's all happened under the leadership of Tim Rice, who's the president. And I know him well enough that he won't take any of the credit for this. But Tim, what has been some of the secrets of your organization being so successful?
Well, I think it's finding the right people. You know, I think when you try to get the right fit, you know, and I think it's the clarity of what we're there for, and our focus is always on the patient. And the priority is quality and service. So I think when you have a clarity of vision and clarity of that focus, and then you just really try to find people who are passionate about that. And so you're right, what's the credit? It is to the people, but if you can be clear on what you're going for and then find the people who are passionate about it, it's just unlimited of what can be achieved.
Well, it's obviously a culture of excellence there, and that goes a lot to the leadership of you and your leadership team.
Thank you.
And I know you're going through the changes and challenges now of the new Health Care Act, which is impacting everyone.
Yep.
And I think we are here at the end of, or into April now, and the time for signing up for MNsure and for the Obamacare is coming to a close. At least they say they might be giving some extensions.
Right.
But it doesn't seem that this is going to be ever reversed. It looks like this is a program that's going in one direction, and that's forward. Is that your view? Do you think that's true?
Yeah, this is a permanent change. I think there's a lot of projections. Well, if there's an election, there'll be changes, but it's not going back. The healthcare industry is in a transition, and it's going to continue to move forward and change.
Well, Minnesota hospitals, I believe you said, are nonprofit.
Correct.
All of them.
Correct.
So how is this new health care plan impacting hospitals?
Well, it's just a whole new way of doing business, per se. I mean, we're going from, I think, to summarize it is, the way the healthcare system used to work before, all the risk was by the payers, Medicare, Medicaid, insurance companies. With this healthcare reform, the risk is now being put on hospitals and physicians. So it's a whole new game.
When you say risks, what do you mean?
Like on payment. So before, they paid all the bills, and if there was a lot of, whatever was work was done, and costs are going up, or there's a lot of cost to healthcare, well, they took the rest of it. Now, the way it's shifting now, that all of a sudden, now with this new healthcare reform, hospitals and physicians are going to be responsible for the overall cost of care. So that's just a whole new change or paradigm of how the business is going to work.
So do you have like an administrative team that just focuses on dealing with all of these rules and changes?
It's pretty much, the whole team is just realizing that how we have to look at how we do everything has got to be different. And again, we're not alone on that. Again, this is nationwide. How, when your mechanism of how you get paid and how you operate completely changes, how do you evaluate, what that is? How do you work with your employees and the physicians about what is changing and how it's going to look? I think the other part of this is that we really don't exactly know how it's all going to look in the end. So we don't even know all that. So in a way, we're kind of like navigating a ship, and we're on the water, but we don't know exactly where it's going to end up, but we do know that there's some elements of it that have to change, and that is we have to control the overall cost better and even provide better care and quality in this new model.
So in the old model, the patients came through the hospital and you sent bills out to Blue Cross and Blue Shield or whomever.
Yep.
And in this new model, that responsibility now is that keeping track of all of that is going to be your responsibility. So that's obviously meant a lot of reduction in revenue for a lot of the hospitals, hasn't it?
Yes, because the basic concept is not quite there yet, but what it's going to be is like we're now going to be responsible for total cost of care, whether it's just hospital or clinic. And I don't even know if people realize 50% of costs of the total cost of care of people are not in the hospital or clinic. They could be afterwards in home care, hospice, nursing home care, pharmaceuticals. So, but we're going to be responsible for the total cost of care, and it's like a set dollar amount. So all of a sudden, when you're responsible for the total cost of care, how do you relook at how you provide that care? Like, for example, do they come to the emergency room, or should they be at a lesser expensive alternative like coming into the clinic? How do you manage their care? And how do we coordinate care with specialists? We started a medical home program a number of years ago, about 5-6 years ago. And what that is, it's a care management program in the clinic for patients with a lot of chronic illnesses or higher cost. And what we did is that we kind of have 24/7 access for those patients, and we manage their care. We have found out that we've been able to reduce their ER visits, their prescriptions, and their hospitalization by 30%.
Wow.
By managing that care.
Wow, that's significant.
Yeah.
Now you have emergency rooms and you have urgent care. Is this new rule or this new law affecting how you do business through those programs?
I think we're just providing things in a better way and less expensive ways for our customers. But so I think overall we're going to see less utilization. I mean, if we're managing it differently. See, really, hospitals before were revenue centers. The more we did, the more we got paid. Now they're all cost centers. It's completely flipped. And so I think we do have an aging population, and we're still focusing always on quality and not just eliminating things, but doing the right things. But I think overall the utilization in those areas will decline. But how will that balance out with the increasing aging population?
Your home care center concept, you were one of the early, or maybe one of the first in the area to do that program, if I remember. Is that correct?
Yeah, as far as a hospital-based home care, there's public health agencies and others. But yes, I think one of the key things where we're excited about it is as far as Lakewood, we really have that full continuum. We actually have, hospital, clinic, but we also have all the senior services. And it'll be interesting to see, in looking at total cost of care, where do all those pieces fit in that are best for patients. And we, at least having them all, we can kind of pick and choose and facilitate and organize that care to be the most cost effective going forward.
Did that mean having more staff going into the homes of people, or didn't that change significantly?
Well, I think that's all coming.
That's coming?
I actually think what's going to be coming is you can be providing care, but what really are the barriers about why they're not improving their health? It could be nutrition. It could be an issue in the home. I actually see us having, and some hospitals are already doing it, where you actually, after a discharge, will have somebody go out to the home and try to assess, are there other barriers about why their health isn't improving? But it's just not going to be care, an episodic experience coming into a clinic or hospital to really help look at total cost of care anymore. It's going to be a completely new model.
When you get rules passed on to you, does that come through the Department of Health, Minnesota Department of Health, or where does that come from?
Most of it's federal.
Federal?
Yeah, as far as the Accountable Care Act, is where a lot of those.
So is that through the Department of Health at the federal level then?
Yeah. And, and the state, of course, they do have elements of coverage, for medical assistance. And Minnesota Care is really state programs. So really we will have both state and federal models that are being developed that we have to adapt to.
We have had doctors on the program who have said this is changing how they do business when they have the patient come into their office.
Yeah.
How is that impacting what they do?
Well, it's impacting them a lot. We now have to have electronic health record. So if you can imagine, everything was done, primarily by paper, but all of a sudden you got to do everything electronically. And how do you get all that to work is a big challenge. People may not realize we have to do coding to get paid. With these new systems, we're going from diagnosis and procedure codes, we're going from 30,000 codes to 209,000 codes.
Wow.
And that's all coming in starting this year. And so that all this ends up on the doctors. And so you just think about all the changes that's going through for physicians and then all employees about having to do everything all differently. It's a huge impact on all of them. And I guess our job administratively is how do we support them and how do we help guide them through, at the same time making sure we focus on exceptional quality and service for patients.
So then do you have to have someone in your organization that gets trained and then goes and trains the doctors on how to correlate all these new codes in the system?
Yeah, we have.
So there's a lot more in-service involved with that?
Yep, a lot of education. We have an HIM department, and their job is to be on top of that all, and how do we help educate and train physicians, and it ends up a lot of work for them, again, trying to get used to new information systems and how does it impact their process of work, and then again, plus all this training and changes. It's huge demand on physicians' time.
We had Dr. Israelson from your hospital on our program here a while back, and she was saying that there's a real emphasis now to go into the community and to start doing activities that can prevent illness. Is that part of being a nonprofit organization, or is that something connected to the Health Care Act too?
It's part of the Accountable Care Act. And whether you're for-profit or nonprofit, you are now required to do a community health assessment. And you have to complete one, and then you have to submit, look at the assessment, set some priorities, and ours happen to actually be obesity and mental health, were the top key health issues, determinants from our area that we're going to be focusing on. We really focus on collaboration. We actually did our community health assessments actually with Tri-County Hospital in Wadena and Todd Wadena Public Health. We actually did it all together. And I think that's the other key part about going forward is we can't be all just doing this alone. We all need to be collaborating together, focusing on community health. And so doing that together, I think we're going to have a bigger impact on those priority community health needs in our area.
So if you were to look at most hospitals now, and if you were to take an average patient walking into a hospital, what would be 3 or 4 things that they're going to notice differently down the road that they saw from when they've been in hospitals in the past?
I don't know if they're going to see a lot of difference. I just think they're just going to see more interaction with their primary care physician. Under this new Accountable Care Act, you're going to need to designate a primary care physician. And now, instead of a patient, for us it's called an attributed life.
Attributed life?
An attributed life. So,
what does that mean?
And what that means now, once they select a patient selects a primary care physician, we're now responsible for everything in that person's life for their health.
Really?
And for their dollars and how that's spent. And the primary care physician is now responsible to facilitate and coordinate that. So I think that's where the biggest change is going to be, is if that physician now knows, as we get data about, okay, what's the total cost of care for that patient, and they're responsible for facilitating, coordinating all that, and also for your health. I think they're going to be more involved. They're just going to have to be, because the quality and payments are all going to be based on, on that inner relationship. And I don't know if people realize too, like they say that 30% right now of healthcare is not needed. And
Not needed?
Not needed because
MRIs or...
Well, there's so many variations in care. So if you look around the country, Minnesota actually has some of the lowest cost per care in the country. And when they've studied it, like for example, other parts of the country they might order 4 times as many tests. But they found that you can do it for a lot less and not have an impact on the patient. In fact, they say that variance of cost within the country in healthcare, and I don't know if this is correct either, but they're saying that number is large enough it could eliminate the deficit.
The national deficit?
The national deficit. I'm not sure if that's totally correct, but just there's, but there's that variation of care. So I think a couple things. So again, I don't know if patients will see that, but I think the fact that physicians now are going to be responsible for that overall health and cost, it's going to change that relationship, but I think in a very positive way.
How about general practitioners? Will this impact their incomes across the country?
I think for primary care physicians, I think that it actually could increase. Because if they're now accountable for that, and that's the main
So
physician.
the good ones who are doing a good job will probably see some potential growth.
Right, and I think for specialists, if they're finding out that maybe that's not needed, I could see it impacting specialist pay. But you bring up a good point. If you're a primary care physician, but you, looking at total cost, but you order a lot more of tests that may not be necessary, your own peers are going to say, you really don't need to do that. And still make sure you're ensuring quality. So even within the groups, I think there's going to be more dialogues between physicians about how they practice. So that'll be interesting to see how that changes.
How about in the area of technology? Is this Healthcare Act going to impact what you do in technology? Because I know you've done a lot of innovative things in the hospitals in technology. I don't even know if you have people that read your x-rays anymore. Sometimes I know that's shipped off to other parts of the world. Yeah. Is that impacting technology in your hospital?
I think that technology will still be a key factor because physicians are really good about not having technology, just have technology. And they pursue technology that's effective in making a difference for patients. So I see that still continuing, that as technology evolves and develops, that we will focus on having what's needed to, that's cost effective. Like there's certain things that we're too small that should be at a regional site, and that'll continue to happen. The interesting part will be, what about technology to the home and the internet, and how will that change as far as care being provided from the home and monitoring back to the facility, and do people need to come in, and will there be certain monitoring through the internet to the doctor? I just think that's all going to change a lot.
The Healthcare Act itself, I suspect, is creating stress in your organizations because of all the change. Yeah. Would that be a fair assessment?
Yeah.
Not having been into that environment, but it's a lot of change.
Yeah. I think the biggest change right now is if going to value, we really cannot. So volumes are going to be going down, and really rates really can't go up anymore, because if you're looking at total cost of care, raising the rates only raises that cost, and then you're above that goal. the only way of really addressing it right now is through, cost reductions. It's really the only option that we have with this. So, and again, the hospital's gone from a revenue center to a cost center. It's just a whole change in mindset. So there is a lot of stress because nationwide we have to look at how do we get those costs under control. And so at the same time, we got to do it at a lower cost and activity going down. It's just a lot of stress to change to a whole new model.
As the president of a hospital, do you think this is going to have more positives or more negatives as we roll down the road with this?
Well, I'm just looking at it, I guess it's my mindset. My kids call me Pollyanna, so I guess that kind of gives the answer. I see everything as an opportunity. But I think there are some key things about this that concern me. Right now, what's the value we're getting with our healthcare dollar? We spend double more than any other country in the world, and our health outcomes are some of the worst. So what kind of value are we getting for that dollar? It's impacting, will it impact in bankrupt Medicare if we don't do something? It impacts employers because here they're trying to compete on an international basis, but if our costs keep going up, pretty much employees are expecting some form of health insurance, so they really got to offer the benefit. So, but I think we just have to have a better value. So I see this as an opportunity for improving our health system as a whole. And I think focusing more on what I like too is how it's focusing more on, can we make a difference on improving health and have the right incentives to make this a healthier nation?
You've had to make some downsizing decisions in your organization, and I know I've been following some of the metro hospitals have made a lot of cuts too. Where do you usually have to make those kind of cuts? Are they obviously not at the physician or the nursing level? I guess they're at other levels in an organization. I would guess.
A lot of it is 60% of our costs are labor in healthcare. So, of course, that is one of the areas. Some of it is just looking at productivity. It doesn't always mean eliminating positions, but in this change in area, that you have to relook at. You can't do it without really eliminating some positions, but it's re-looking at things in a whole new way, and still not impacting quality or service. That's a challenge. But you just have to relook at it in a different way, and really it's getting. You try to do things, through retirements, transitions, but depending on the level of change and the pace of it, sometimes you just can't wait and you got to make that move.
How about the young people? If there are young people who are not enrolling, 25-year-olds, 30-year-olds, when they come to the hospital, if in 2 years down the road they don't have an insurance, I know they'd have to pay a penalty. Are you still obligated to work with them as you are now? Does that change?
Yeah, we have, and most hospitals do, we have a community assistance program. And we're always trying to look at the gaps that people have. So I'm trying to think last year, we do provide, I think it was up to $2.5–3 million of what I call discounted or free care that we gave. But if they're coming in and they really have, we're not going to turn people away. And so we need to take care of them. And so, but if they don't have anything, they don't have anything. Why try to spend all this money on trying to collect something if it's not it's not a planned thing, and you have a medical need or emergency, and you have the high cost, so instead of spending the money on collection, we just offer discounts depending on income levels. And actually, we're restudying it right now with this new health insurance exchanges. More and more people are going to have access to coverage, but some of the plans that people are selecting, they're low cost, but they have really high deductibles, up to like $12,000.
Wow.
So now we're shifting our community assistance to those people who are selecting coverage, but based on their income levels, they're not going to be able to pay it. May not even realize they could have up to $5,000 to $12,000 deductible.
That's a pretty large deductible.
Yeah, and so So we're adjusting our programs to try to make sure we're helping those patients out.
Wow. Well, it's a fascinating time, and I think the last time we had this kind of a major change was when they introduced Medicare, Medicaid, and I know there were issues with startups then, but probably not of the notoriety that we have had in this particular program. But it does seem to be settling down a little bit, and it seems like more, I don't know that every state still bought into it, but it's hard to imagine that eventually they won't all buy into it. When you start hearing stories now of people who are saving money, there's a lot less being spent in some areas. So it's a fascinating area, and thank you for taking the time to come on and help us understand how this is impacting hospitals. And your hospital will be a particular one to follow. We're, I guess, blessed to have such really good hospitals in our central Minnesota area. Up and down the east and the west side here, we have some very good hospitals.
Yes, we do.
So it's going to be interesting, and we'll have to have you come back in a year or so and tell us how it's going.
Okay, be honored. Thanks for having me.
Thank you, Tim.
You bet.
This is our last program of the year. This is our 6th year. I'd like to thank Nisswa Tax. They have been with us since the very beginning of our program, and we appreciate that support. We run, of course, from April, or I should say from October through April, and at the end of April, you know, it's fishing time, and so we got to all take a little time to go out and fish and watch a baseball game. So thank you very much. You've been watching Lakeland Currents, where we're talking about what you're talking about. I'm Ray Gildow. So long until next time.